Good morning, and at the outset, one more great opportunity to come to this land of Meenakshi. I have no disclaimers for this talk, especially I have not used AI. The topic given to me by our friend Kumaravel is primary versus secondary hypogonadism in men. நல்ல வேலை சித்ரா செல்வன் மாதிரி வந்து உல்டாவா ஆண்ட்ரஜன் இன் விமன் நல்ல வேலை ஈஸ்ட்ரஜன் இன் மென் அதில் பிரைமரி செகண்டரிலாம் கேட்டிருந்தா இட் வுட் பி மோர் தியரிட்டிக்கல். வி யூஸ் டு பி ஆஸ்க் தீஸ் கொஸ்டின்ஸ் டியூரிங் அவர் வார்ட் ரவுண்ட்ஸ் அண்ட் many times in seminars we present this. In DM seminars will be always the ulta question. Anyway, that will help you to understand endocrinology at a deeper level, and you will apply those principles in a broader sense. So for the next almost we are given 15-16 minutes more. I will quickly give you a brief outline of how we approach hypogonadism in men, and what do we mean by primary, secondary, and how do we approach clinically. Please spend few seconds extra on this slide to tell us that testis, which is the primary gonad, the primary sexual characteristic of a male, has two important components, both functionally as well as anatomically. One is the major bulk, which is the seminiferous tubule which synthesizes sperm, and spermatogenesis is the main function of that. The second is the Leydig cells, which are secreting the main male hormone, which is testosterone. So functionally as well as by endocrine control, these two have to be at least conceptualized as separate. Testis has both. The Leydig cell component will be less than 5% of the testicular mass, but the sustentacular Sertoli cells and the seminiferous tubules form the bulk of the testis. The intratesticular secretion of testosterone by these Leydig cells and its paracrine action is talked about in a big way in spermatogenesis actually. And we all know that this beautifully exemplifies the three-tier endocrine feedback system: hypothalamo, pituitary, in this case the effector organ is testis, and where very, very interestingly and intriguingly, two different hormones from the same cell of the pituitary, which is gonadotroph, under the influence of a single hormone called GnRH, actually controls these two components separately. Then how does it do? It is probably by several experiments they found that the amplitude of the GnRH secretion and the frequency of GnRH secretions varies. Based on that, the gonadotroph will secrete either LH or FSH. This is very, very intriguing. Anyway, but these have been, we have to thank all those great scientists. This is all thousands of PhDs in one slide, and I'm just reciting what I have memorized over several decades now to know this. And the feedback is not only by testosterone. We need to remember that one more hormone called inhibin. This will be usually a question asked in our, again, endocrine discussions. You see, testosterone has a feedback effect primarily on LH. The FSH is not under that great a control from testosterone. Mainly the FSH is inhibited by inhibin, which is secreted by the Sertoli cells. All these are developing during the first 12 weeks of intrauterine life, from the area of the mesoderm where adrenal gland, kidney, and these are developing together, and the testis actually descends later downwards. So, and one of my anatomy professors, I can never forget him, Professor Cooper. If there are people from Madras Medical College or Stanley will know him. We were fortunate to be there with him. Then he will always stop in between his lecture and say, don't forget all these came from one cell. All these complexities which we are discussing actually has been chipped in one cell. And that cell divides into multi-trillion cells which you are sitting here. Anyway, it is even more intriguing, and I will not spoil the Saturday morning of a pre-festival season of Madurai by all these kind of reciting all these factors which control so many neurotransmitters proximal to hypothalamus. You can imagine one of them is very, very important, that is called, they say, this whole axis get activated, this GnRH, LHFSH, testosterone, inhibin, whatever. This axis gets activated somewhere around 12 years. How does it know it is 12, 11? What kept it under abeyance till then? Secondly, this starts with a kiss. The GnRH has one more important factor from the prefrontal cortex and other areas called kiss peptin, which actually triggers it. So you can see there are so many inhibitory and stimulatory factors to this pathway. And if you want to write an essay on genetic control of this pathway, you add several genes for each of this. For example, if you don't know what it is, you can say it could be a repressor, it will be a controller gene. If time permits, I will comment on, today we are sending genetic tests like how we used to send hormone tests. And we get all funny reports, many times not explainable. We send for one disease and another disease turns out in that patient. And if in a given patient it doesn't come, they give explanations, which I am learning slowly. At the intron la irukum sir. It is not in the exome amcha only whole genome anpuga. Genome amcha mottama anpuga vendiyadu. There is no way, it's like, panel, there's ellarku whole genome da mananu innume. So these are all esoteric and more theoretical probably, but the most important clinical point is this axis is under the influence of multiple clinically accessible parameters, which includes the environmental influences, disruptors, nutritional status. You need a critical body mass of the fat mass. That's why around the 10 to 12, probably the leptin signals, we don't know. You'll be interested to know that it will be always at the bone age of around 11 to 12, all these starts. So there is a link between bone and this axis. And we needless to say that there are other endocrine organs, especially thyroid, has an overall influence on this whole system. How we know that hypothyroidism always delays this axis. Uncontrolled diabetes mellitus, which acts like a systemic stress, and multiple systemic inflammatory disorders, including rheumatoid, celiac, X, Y, Z, you can add anything, can influence this. That's what is our clinical approach. So by now you would have got the idea that this gonad called testis has two components. One is the hormonal component, other is the spermatic component. Hypogonadism technically will mean both. However, for all general discussion purpose and because of the ease of replacement of the hormones, we always mean whenever we say hypogonadism as testosterone or androgen deficiency in a male. The primary hypogonadism, which means primarily testis is affected. That is, testis is affected means it's primary. In contrast to so many other branches of medicine where in pulmonology or nephrology, when you say primary nephrotic syndrome, it is idiopathic. Secondary means secondary to drugs or infection or X or Y. It's not so. In endocrinology, primary hypothyroidism means primarily thyroid gland is affected. If that endocrine gland is affected due to a pituitary condition, secondarily, that is called secondary, that condition. Here we are discussing gonad, so secondary hypogonadism means testis or ovary is affected. Today we are discussing only male, so testis is affected due to a pituitary pathology. When I say pituitary, hypothalamus is also included. We always discuss that as a unit. If there are pundits and purists in endocrinology, they will say tertiary in solalam, and you have only GnRH deficiency and only hypothalamic dysfunction. So this has to be always remembered. Primary hypothyroidism, thyroprivic hypothyroidism. This is primary testicular dysfunction, means testis is affected due to some pathology. It could be congenital. That I will come to in the next couple of slides. So as you can see here, again I am not going to recite all this. Again, I remember my senior who gave us a mnemonic when we were MBBS, cat in bed abdima, congenital, acquired, traumatic, infectious, neoplastic. You can add or whatever, environmental, drugs. Anything which affects the testis directly, either during the testicular embryogenesis or it could be due to injury, etc. And many of which have clinical clues I will come to. You have to take a history accordingly. So that's why always you should know some idea of what are all the causes before we ask history in a given patient. good history in the form of surgery in the neonatal period or hernia, etc. Some clues like mumps, all these are not uncommon. You should ask, dig out into the history. In contrast, you see here in secondary, you have any condition which affects the hypothalamo-pituitary area. That could be again genetically during embryogenesis itself, or it could be due to the last part. This is what is more interesting in adults today. So the prototype of primary for all our practical purpose to remember as a case example is Klinefelter syndrome, which is a genetic condition. It is difficult to pass to the next slide before saying one word about Klinefelter. In fact, Klinefelter syndrome was not discovered by Klinefelter. If there are PGs from the Madurai Medical College here, it will be worth remembering history. It was the great man Albright, Fuller Albright, who actually discovered everything what we know about Klinefelter syndrome, and then he gave it to his student Klinefelter. You said, you work up further and you put your name. So it's all Albright's magnanimity. Great people like Albright were also there, Klinefelter's guru. Anyway, this side is the pituitary hypothalamic problem. Invariably, this is hypothalamic in nature, and can call it Kalman if there are some features, and a host of other conditions are there. I will not read out everything, but more importantly, for clinical purpose, somebody very obese, chronic systemic illness in a male, especially COPD or steroid intake for systemic inflammatory conditions, even uncontrolled diabetes mellitus, hyperprolactinemia of other etiologies, etc. Last one, very, very, very important. She said about in the previous talk, Dr. Chitra, about misuse, abuse. Females kyarum kudukalla, males most abusive. You go to maximum prescription of growth hormone and testosterone is by whom, Which branch? By gym people, non-medical people. Adla ipa semaglutide seithukalam. I pause here with an eerie silence and pray God and Meenakshi that these things should change in our society. This is extremely unfortunate. Anybody coming with low LH, FSH, anybody coming with spermatogenic defect, sperm analysis defect, it will be invariably some misuse of androgen somewhere. And today we have a number of preparations, oral and other things also. So, India in the corticosteroid and sex steroid pesina, we actually we cannot get away from the fact that how much ever regulatory bodies are there. You can't blame the government for everything. What happened to our education and what happened to our honesty if everything has to be misused? So we are doing a disservice if we give testosterone to males for any non-specific reasons, and they will have all the problems due to this. So the clues to clinical clues, etc. The onset of hypogonadism, which I said already, it could be seminiferous tubule or hormonal. For all practical purpose, we discuss only hormonal component, can be dated depending on other features. For example, a child which has a male fetus during the first 3 months itself, genetic problem means it will not only have low testosterone and undescended testes, it could have even under-virilization of the external genitalia leading to ambiguous genitalia. Anything after 3 months, any insult to the fetus will lead to microphallus without ambiguity, and later in the trimesters you will have only microphallus. All these are clues for early onset. That's why even if a male presents to you at the age of 19, 20, 25, whatever, primary infertility, they can come with anything. Your history should go into antenatal history, amma kennachu, whatever, etc., during birth, post-op, immediate neonatal period. All this will carry a lot of meaning, and standard teaching in endocrine units will be on. You should, the presenter should say that this patient has a problem which I think dates back, so I start with the birth history. And clues regarding, see, the testosterone deficiency is common to both primary and secondary. The only thing which will be different in the primary is the seminiferous tubular dysfunction also will be, irreversible more often. So low energy, low libido, etc., etc. Small testis, small phallus will be there only in prepubertal onset of hypogonadism. Post-pubertal, invariably the testis will be more than at least 8 ml. And if they had normal puberty, but later coming to us with something, that's actually a good sign, we can do something about it. So many of these written here are actually testosterone deficiency symptoms that will not tell you whether it is primary or secondary. Primary or secondary will be only from clues which we take history from hypothalamic pituitary point of view or testicular point of view, or you have to do the gonadotropin assay. Thanks to our ESI, I happened to write this chapter on male infertility. We slightly tabulated, adding few points from our point of view. Like for example, somebody with hypopituitarism in tropical countries sometimes can be due to snake bite, the viperine bite also. These will be added only in our textbooks. Mumps orchitis will be always missed because if they have unilateral parotid enlargement and if it passes on without any major symptoms, you will miss it. All others like cartilaginous, cystic fibrosis, all these are to be only history. History will only be, I wish my postgraduates are here. How many times every other day we are documenting that only history will clinch the final diagnosis. The threshold to send fancy investigations have taken a toll on our ability to analyze historical symptoms. Examination again should be thorough. If my boss was here, even in general medical patients, I remember even now I tell my PGs, a patient with renal failure, acute gastroenteritis and AKI got shifted into our ward because we had medical unit also during our training. Iska shakal theek nahi hai, which means he is not looking normal, he looks hypogonad. Did you examine his testis? See, he is CKD, AKI patient lying down there. Testis examine panlana, absolute, that's a disservice to that patient. So testicular examination, primary infertility. He came for AKI, but we diagnosed him with primary testicular infertility due to most common causes Klinefelter actually. So simple examinations, astute observation of his muscle mass, hair distribution, voice, smell. Smell you have to dig into it. This hyposmia you cannot pick up if you ask this. And you have to ask more of, எல்லாருக்கும் உங்களுக்கு தெரியலையா வீட்டில் ஏதாவது சமைக்கும் போது அந்த நெய் வாசனை வந்துதா கோயிலுக்கெல்லாம் போவீங்களா இல்லை எங்கே போனால் பூ வாசனை தெரியும் அவங்ககிட்ட ஆமாம்மா எனக்கு கொஞ்சம் கம்மியாக தான் தெரியும். You dig for extra 2 minutes to know the history. Otherwise you have to do formal testing. உடனே University of Texas ஓட smell analysis எங்கிட்ட இல்லைன்னு சொல்லக்கூடாது. எல்லாரும் பரிகார டப்பாயோட எல்லாம் சுற்றின்னு இருக்கவும் முடியாது. We did only for our MD exam. And again, as I mentioned, examination is always, start toe to head and genital examination and looking at the scars, etc. Sometimes this mirror movement, all these are important. This is the two only instruments endocrinologists have. One is this orchidometer and the inch tape, and here it is a caliper. Okay, இப்போ இந்த பாடி காம்போசிஷன்லாம் ஏதோ தெரியாதனமா வந்திருக்கு இல்லைன்னா the only thing is this. இது எல்லா வாட்டியும் அந்த ஸ்பாட் வைப்பாங்கல்ல MBBS மேல. This is the orchidometer and please you have to compare it along with this. இதுல ஒரே பிரச்சனை, இது இந்தியா கிடைக்காது, வெளியில இருந்தா வரணும். நம்ம இப்போ எல்லாம் வந்துருச்சு தேங்க்ஸ் டு இதை நானே பண்ணினேன் அப்புறம். Anyway, then the caliper வச்சு you can measure the length also in one nice urology book. Seeger's orchidometer. This can be leg pulling for our PGs, Seeger's orchidometer na enna kekkalam. That is length. And secondary hypogonadism clues. There are only 1 or 2 features here which will classically differentiate the two. Prepubertal onset, small testis, small phallus. Unicoid proportions will be only there if prepubertal. Gynecomastia will be in it. Then the post-pubertal enna arthomna adults coming with pituitary tumors, adult with head injury and hypopituitarism, those kind of things, or adult with a trauma which caused the thing. Those fellows, and the trauma testicular deficiency you'll have all the features. But pituitary, they will respond very well. Why should I discuss so much on primary and secondary? First of all, to differentiate, in addition to clinical examination, pointing out hypothalamo-pituitary problem or testis, you should check these basic hormones and do imaging appropriately if necessary, especially for pituitary. And as was pointed out by Dr. Chitra also, whenever you measure testosterone, do not send free testosterone. Check only total testosterone, even in males where the values will be reasonably good in nanogram per ml, and normal liver functions, they should not be on any other therapy. And if at all you want free testo, that can be done as LCMS and other things, LCMS. So this simple algorithm, clinically dig into milk, dig into the history as much as possible, get all clinical features of possible hypogonadism or hypoandrogenism. Then you are convinced, check with testosterone levels, measure LH and FSH. This is the most important step. No AMH, no inhibin B. Okay, and these two assays are fortunately very reliable now. If the LH and FSH are quite high, which means in double digit, 10, 15, 20 or more, it confirms that the pituitary is not able to drive. That is called primary hypogonadism. If the LH-FSH is low or normal, which is inappropriately normal for low testosterone, that is called secondary hypogonadism. Then you have to image the pituitary. This is algorithmically. Then you have to treatment will be testosterone based. I'm not going into it, we can discuss if time permits. India we have only injections, we have gel, but in our sultry weather and sweating, many times it doesn't work well. Fortunately, we have these depot preparations which are very useful. And we have to monitor, in addition to symptomatic improvement, hematocrit, OSA and prostate. This one slide is the most important. There are reproductive physicians, gynecologists here. Secondary hypogonadism is amenable for fertility restoration. Primary testicular failure, whatever be the etiology, it invariably affects the seminiferous tubules also. Very difficult to restore fertility if the damage is more than what we expect. So the idea of discussing this in great detail is to identify our secondary people. If you palpate the testis, itself will tell you whether the testis is more than 4 ml or 8 ml, it is post-pubertal, then it means the prognosis is good. If it is less than 4 ml, small, naughty, then you are gone, that testis is already affected for a long time. And if it is bilateral, it is not going to work. So in summary, this hypogonadism conditions is a very big spectrum. People come with all low testo deficiency, netlalam paathu questionnaire la avangale fill panni enak irukku avangale varanga ippala. You have to be objective in your approach, clinical in your approach, as well as do the test assays which are highly reliable in your setup. Total testosterone, LH, FSH, prolactin, thyroid. This will give you the answer in 99% of the patients, which direction it is going. Then you counsel them, do not reflexly replace. Systemic illness, exogenous therapy, always keep in mind that in India you have every alternative medicines, everything will have some intermediate metabolites which can confuse the picture. Thank you very much for your kind attention. Thank you.